The renal failure can be multifactorial. There might be a decreased renal gluconeogenesis. So, gluconeogenesis contributes to 10 to 20% of the glucose comes from the renal glucogenesis, which is decreased in the presence of renal failure. So, as such, the renal failure patient will have a decreased caloric intake, and at the same time, there will be decreased clearance of insulin. That is the reason typically when the patient are on insulin, they might be predisposed to more amount of hypoglycemia. So the decreased renal clearance of insulin, or otherwise in a non-diabetic also can happen, and there is a decreased metabolism of other medications that can cause a hypoglycemia. Could be alcohol, could be a drug. All these things can go for decreased metabolism of other medication, which can cause a hypoglycemia. So the problem with renal failure, even among the diabetic, they can go for hypoglycemia. Even among the non-diabetic, it can go for hypoglycemia. So the insulin sensitivity may improve in uremic patients after starting renal replacement therapy, which can contribute to increased risk of hypoglycemia. So the sensitivity also can be improved, as we saw in alcohol. Once you start the patient on renal replacement therapy, which can also predispose the patients to increased risk of hypoglycemia. So these are the three important things why these patients can go for a hypoglycemia. One is alcohol, the second is liver, the third being the renal. Now there comes an important factor, like we need to understand if there is an IGF-2 mediated, if there is a presence of malignancy with a cerebral metabolism, there might be an IGF-2 mediated increase in the incidence of hypoglycemia. So what happens in the presence of insulinoma? What happens in insulinoma? Insulin gets produced, the beta cells become bigger, they are able to produce more amount of insulin. There will be an increase in the insulin level, there will be increase in the C-peptide level. The patients will be going for, because of the increase in the insulin, which are produced uninhibitedly. So what happens in insulinoma? There will be an increase, the insulin is getting produced from the beta cells in a non-inhibited fashion. The insulin is getting produced, so there will be increase in the insulin level, there will be increase in the C-peptide level, but at the same time, as the insulin is produced, as we said, uninhibitedly, there will be a hypoglycemia. So this is what happened there will be hypoglycemia. The blood sugar level decreases and it causes hypoglycemia. So this happens in insulinoma. On a similar fashion, in IGF-2, since the IGF-2 levels are increased, these IGF-2 levels can act in various receptors. It can act in the liver, or it can act in the peripheral tissues also. It can act in the muscle also. So when these are acted, so when it acts on the liver, the glucose output is decreased. So because this insulin, the IGF-2 factors are going and sitting on the insulin receptors, so they are able to inhibit the production of glucose by these cells, like how the insulin does. So the glucose output is decreased. At the same time, like how the insulin does, it acts on the fat cells, whereby there is it goes and sits on the receptors. It causes a decrease in the lipolysis, and there is a decrease in the free fatty acids also. So the substrates are also decreased with IGF-2 elevated levels. So when the substrates are also decreased, this will produce for hypoglycemia. IGF-2 acts on this free fatty acid, whereby the substrate level decreases. So the substrate level decrease causes hypoglycemia. Now the IGF-2, which acts on the muscle, it can cause, like there is a decrease in the glucose uptake, because these receptors, they are with these muscle receptors have the insulin receptors in the muscle have a constant exposure to the higher level of IGF-2. Since it is sitting permanently over there, the muscle are able to take lots of glucose. The glucose uptake is increased. At the same time, since there are no more substrate, since there are no more glucose that is coming, the patient will be going for hypoglycemia. So the hypoglycemia over here is three-pronged. One is there is a decrease in the substrate. It sits on the receptors in an uninhibited fashion and facilitates the glucose which is taken by the tissues, and there is no negative feedback mechanism which is happening, but still it keeps sitting over there, making the glucose whatever is available to get utilized. So there are no more substrates, so it predisposes to hypoglycemia. At the same time, it sits on the liver and produces decrease in the glucose output. Gluconeogenesis is decreased, whereby that predisposes to hypoglycemia. So the IGF-2 on all these fronts, it causes hypoglycemia. But at the same time, since the hypoglycemia is happening, at the same time, since these cells are taking the glucose, the reflex mechanism happens whereby the insulin level is also decreased. The adequate substrate is going into the cell because the receptors are fed with IGF-2. So it presumes there is a pseudo insulin level which is happening over here. So in insulinoma, there will be an increase in the level of insulin, there is an increase in the level of C-peptide, whereas the IGF-2 mediated pathway, there will be a hypoglycemia, but the insulin level, if you see, it will be decreased. So this is what differentiates an insulinoma from an IGF-2 mediated pathway, because there is a pseudo hypoglycemia which is happening, which is making the insulin to produce it, it stimulates, it gives a feedback as if there is an adequate amount of glucose which is happening. So the cells are not able to perceive this low sugar, and insulin is getting produced in a decreased quantity. As they are able to sense at the level of muscles, there is a normal or adequate intake of glucose which is happening because of the IGF-2 sitting on the receptors. So hope this is clear. This insulin decrease is the one which makes it differentiate between IGF-2 and insulinoma.